So, this lecture is over the nervous system assessment and the diagnostic test for different neurological disorders. So, the first thing we'll talk about is doing a focused neuro assessment and the data that you would collect while doing this. So, the first thing we want to do always is collect our subjective data so we know that that data is gathered by talking with our patient and asking them questions. So, one of the first things that we always should do with a neuro assessment is determine any sort of characteristics of a present illness that is occurring. Because if something is presently occurring, then we need to consider that a more acute emergent situation and move on to addressing that issue. So, the easiest way to do this with neuro patients is just by assessing how alert and oriented somebody is, their level of consciousness, those types of things. So, we can easily do this one just by looking at our patient and then also by asking them, their name, their date of birth, where are they, what's going on. Those basic questions we need to assess, are they alert? Are they drowsy? Are they lethargic? Are they comatose? Those types of things. To let us know if something more serious is going on and that we need to take action. So that would be the first thing that you'd want to do. And then if everything seems to be okay, there's no change in their baseline, then you can move on and ask them the questions that go along with that subjective neuro assessment. Something else that's really important with neuro patients is to always know their baseline. So know how they are normally, how they act normally, if they have any deficits from something that they previously had, like a stroke or something like that. So that way you know what the patient's baseline is. That way, if they deviate from the baseline, you will know that there's an issue going on. So some important things to take note of would be birth history. Sometimes people experience a traumatic birth, which can result in some neurological issues such as cerebral palsy. Do they have a history of a TBI, which is a traumatic brain injury? Have they had a history of a stroke? Do they have a history or a current diagnosis of some sort of degenerative neurological disease like MS, ALS, something like that could affect them neurologically? Those would be important things to note. Or do they have something like Alzheimer's or dementia? Medications that you would want to discuss would be medications such as sedatives, opioids, anything that could affect their level of consciousness, or any other type of neurological medication like seizure medications, or medications for like anxiety, depression, those types of things that can affect somebody neurologically. You'd also want to know about any past surgeries they've had specifically on maybe their brain, spinal cord, things that would affect their neurological system. And then you would want to know just overall their growth and developmental history throughout their life. Were there any delays? Are there any cognitive delays, or like motor delays, anything like that in the patient? Something else to be aware of is if we know somebody has something neurologically going on, or we suspect that they do, or they already have a diagnosis of it, we need to determine if they're a reliable historian or not. So are they going to be able to give us accurate information about themselves and about their health? If we determine that they aren't, then it may be important to discuss their condition with somebody else, such as a spouse, a caregiver, somebody who lives with them, somebody who's close to them and knows them, to get the accurate information we need. It is always important, of course, to ask permission from the patient first to discuss their care and their health with somebody else. As far as more subjective data that will collect, health perception, this is a big thing with neuro. A lot of the times when people do have some sort of neurological condition, they are unaware of it, especially like dementia, Alzheimer's. They may not see that something is going on, or they may see it, but they're unwilling to accept it or express that. So once again, it can be helpful to ask the caregiver or spouse if they've noticed any sort of changes in the person. If they have noticed changes in the person, we would want to know how this condition is affecting their daily life, their ADLs. Are they able to perform the things that they usually did in the past? Are they able to live like they usually lived, or are they starting to have issues? As far as nutrition goes, we know a lot of neurological things can affect how somebody chews, swallows. So those can result in malnutrition, vitamin deficiencies. It can result in aspiration. So that would be important to take note of. As far as activity, exercise, neurological issues can also affect strength, mobility, coordination. Is the patient a fall risk? Are they unable to perform certain activities? Elimination can be affected by neurological issues, especially like spinal cord problems or MS. Those types of things can make elimination difficult for a patient or cause issues with it. And then sleep and rest can also be affected by neurological issues. So either neurological issues can cause somebody to not get adequate sleep or rest, or if somebody is not getting adequate sleep and rest, then they can start to have neurological issues. So it can kind of be that like chicken and the egg situation. So things like pain, inability to switch positions, so like mobility issues, dementia, drugs, sundowning, all those things can affect people's sleep, and then they can be worsened by not enough sleep. So those things are really important to take note of and ask the patient or their caregiver about as well. And then more functional health patterns, as you can probably see at this point, anytime somebody has something neurologically going on with them, it can potentially affect every aspect of their body and how they function. So it's really important to go through all these with your patient. The cognitive perceptual pattern, you would want to take into consideration the patient's culture, age, their education level when you're assessing the patient, because how they perceive what's going on with them and how they handle it could be different based on their age, their culture, those types of things. So some people may consider themselves to be very independent. They don't want to ask for help, so they're not going to express that they're having issues, while somebody else may be completely different. As far as all these other things, each one of these things can be affected by some type of neurological condition, and this can really affect somebody's mental, emotional well-being, especially for people who've recently had maybe like a stroke and now they have new deficits, or they've recently been diagnosed with a neurological condition and they know that down the road they're going to start to experience problems in these different areas of their life, like their sex lives or their relationships or their abilities to take care of themselves. And that can be very mentally and emotionally distressing for them. So it's important to evaluate all of that in your patients as well and help them find ways to deal with that and cope with it. So moving on from subjective data to objective data. So objective data, remember, is what we view as the nurse or what we assess as the nurse and the data that we gather. So I've kind of mentioned this already, but the first thing we always want to do with our neuro assessment is get a good like mental status of the patient. So first we want to determine how, if they're alert and oriented times 1, 2, 3, or 4, determine their level of consciousness. Are they alert? Are they lethargic, sleepy, those types of things. And then also we can just take a good look at our patient and get a good idea of their general appearance, their behavior, how they're acting. Are they awake? Are they asleep? How are they dressed? Do they look disheveled? Do they look put together? What is their mood, their affect? Are they agitated? Are they angry? Do they kind of have just like a blank, expressionless affect? Are they laughing inappropriately, crying inappropriately, or does their mood seem to match what is going on? Something else that we would want to assess would be like their cognition and their memory. So there are ways that we can do that. One of the simplest ways that this is done is through typically you'll see this done at their admission assessment. You'll tell the patient, I'm going to give you 3 words and then I want you to repeat them back to me. And typically those words are apple, table, and penny. And then later on in the assessment, you'll ask them to repeat those words. And if they're unable to repeat them or have difficulty with it, this may prompt you to do a little bit more thorough exam on their memory and their cognition. And so that could prompt you to do something known as the mini mental state exam, or the MMSE. It has a series of questions. It has a way to score it, and that can give you a little bit more detailed insight into the patient's cognition and memory. Something else that you would want to assess for would be delirium. So, delirium is an acute problem. It is not something that somebody chronically experiences or just has all the time. Typically, it can be an indicator of other illnesses or something else that is going on. It often happens to really sick patients, typically those patients who've been in the ICU. We think, or people who've been hospitalized a long time, and we think it's just because their normal way of life and schedule has been constantly interrupted. They are overstimulated by lights and beeping and people waking them up at all hours. They're not getting adequate sleep. They're being poked, they're being prodded, all of this stuff. And so sometimes people can end up becoming delirious, and that affects obviously their behavior, their cognitive status, all those types of things. So there is an assessment I know at OHRH that you can do to determine if somebody is considered delirium positive. So that would be something that you would want to take into account as well. So next we're going to move on to the cranial nerves. There are 12 cranial nerves, and they are listed here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. You do need to know the name and the number. That is important. It's just one of those things you need to commit to memory. So you need to know the name, the number, what they control, and how you assess them. So we will start with number 1, which is known as the olfactory nerve. This is cranial nerve 1. It controls our sense of smell, and it's simply tested by having the patient close their eyes, and then you'll put something up to their nose and have them smell it. It's typically something that is commonly recognized by most people. Something that is often used would be coffee, because most people know what that smells like. Obviously, if they can't smell it, then their cranial nerve has been affected and they have a loss of sense of smell, which is known as anosmia. We see this now more often than probably we used to, and that is because of COVID. And we noticed that people were losing their sense of smell with COVID, so that's probably an indicator that that cranial nerve may have been affected with that virus. And then the next one we'll talk about is cranial nerve 2, which is known as the optic nerve. So this nerve has to do with vision, and I think of it as it has to do with how well we can see, like how clearly we see things, and the areas that we can see. So the first thing that we would assess would be the visual field, and we can test that through like checking their peripheral vision. And so an easy way to test that would be have them put one hand over their eye, and then you would hold, like say you put one hand over your left eye, you'd hold your fingers out from their right eye, and you'd move them around, and you'd like maybe change your fingers to 2 fingers, 3 fingers, 4 fingers, 5 fingers, and have them tell you how many fingers you're holding up in different areas of that peripheral vision view. Obviously, if they are unable to tell you or they don't get it right fairly often, that there could be some visual peripheral field vision issues. They can also have issues that are listed here known as hemianopsia, quadrantenopsia, bitemporal hemianopsia, and monocular vision. And so what these different things indicate are their visual fields are affected. And you can see listed here the ways that they are affected. With the bitemporal hemianopsia, it's the outer halves of both eyes that are affected. So that is your peripheral vision that is affected. Typically, with the hemianopsia and the quadrantenopsia, it would be like the inner fields that are affected. And then the monocular vision is they can only see with one eye. And then the top 2, hemianopsia and quadrantenopsia, typically this does affect both eyes. You can see this sometimes like with strokes and stuff, their visual field will be affected. And then visual acuity is how clearly or how well we can see something. And we discussed this already in your like visual lecture on exam 1. So easiest way to test this would be with the Snellen chart. You'd have them, and that's the big chart with the E, you'd have them stand 20 feet away. They'd cover one eye. They'd read the smallest line they could, cover the other eye, read the smallest line they could, uncover both eyes, and read the smallest line they could. And that could tell you how well they can see far away or how clearly. So those are ways that we can assess the optic nerve. So remember, optic nerve, cranial nerve number 2, that is our visual field. So the areas we can see, and our visual acuity. So how clearly or how well we can see something. The next nerves are cranial nerves 3, cranial nerves 4, and cranial nerves 6. So that's oculomotor, trochlear, and abducens nerves. These are all tested together. And that is because they all like control the same thing. They all help control the movement of the eye. So when I think of these nerves, I think of the actual movement of the eyeball or the structures of the eyes. So extraocular movement, the easiest way to test this is by taking like a pen, your finger or something, holding it out in front of the patient and telling them to follow the pen with only their eyes. And you'll either draw like a star shape or an H. And that tells you that if they can follow that pen properly everywhere, then that's like the 6 cardinal fields of gaze. And that tells you that they can see in all those areas, that their extraocular movement is intact. And then as far as pupillary constriction goes, remember that's how our pupils react to light. So you would take a pen light, have them cover one eye, shine the light in their pupil, and it should constrict when the light is shined on it. Also, you should uncover the eye, and when you shine the light in the right pupil, the left pupil could constrict, and the same for the other side. And so that's like a consensual reaction. We want to see that. And then accommodation has to do with like seeing things, your vision being able to like kind of accommodate as things move closer or further away from you. So the way that you test that is you would take a pen or your finger, hold it out in front of the patient about arm's length, and then slowly draw it towards the middle, like towards their nose, and their eyes should start to deviate in and their pupil should start to constrict. That is known as accommodation. I see a lot of students get confused about that, but that's what that means. And then also these nerves control like our eyelids and if they're held up or not. So if we see eyelid drooping, which is known as ptosis, we would know that possibly something is going on with one of these 3 nerves. And then the next nerve we'll discuss is the trigeminal nerve, which is known as cranial nerve 5. I like to call this the cat whiskers nerve. And you can see here on this little smiley face, I have the cat whiskers on it to remind you. I call it that because the trigeminal nerve has 3 components to it, hence the name trigeminal. And they run along your face in 3 different areas. So you can see on this smiley face, they run along here at the upper part, like under your eye. That's known as the ophthalmic region of it. Then the maxillary region runs right across your cheek. And then the mandibular region runs at the bottom, like kind of from the corner of your mouth down toward your jaw. So those are the 3 regions of that. And it has a sensory component and a motor component to it. So to test the sensory component, we would use the sharp dull test. And the easiest way to do that is like with a Q-tip or something like that. I've seen people break the Q-tip in half. And the sharp part is the end without the little cotton ball. And then the dull end is the end with the cotton ball. You'd have the patient close their eyes. You'd tap each end on their face in those different areas and have them tell you, is this sharp or dull? You typically say, does this feel sharp or dull? Or you would say, how does this feel? You'd want to make sure that you tested it in all 3 divisions, and you would want to make sure that you tested it on both sides of the face, and you'd want to know any sort of asymmetry. So can they feel it on one side, not the other side? Can they feel it in certain areas, not other areas? And then the motor portion of it has to do with clenching their teeth. So what you would do is you would have them clench their teeth together, and you would just palpate that mandibular angle, which is like that kind of like jawbone area right underneath your ears. And you should be able to feel them clenching their teeth. So that is the trigeminal nerve. So remember, tri means 3, and that's because they have those 3 cat whiskers going across their face. The next one is cranial nerve 7, cranial nerve 7, which is known as the facial nerve. It only has a motor component to it, and it has to do with how we move all the structures on our face. So it's pretty easy to test. The way you would test this on a patient would be to have them raise their eyebrows, close their eyes tightly, purse their lips, smile, frown. You'd want to make sure that they can do all of that. And once again, you'd want to know, is there any sort of asymmetry? So does their smile droop on one side? Can they only close one eye, not the other? When they raise their eyebrows, does one only go up? Those types of things. And then the next nerve is cranial nerve 8, which is known as the vestibulocochlear nerve. There are kind of two components to it. There's the vestibular branch and the cochlear branch. The vestibular branch has to do with balance. Typically, it is not tested unless somebody is complaining of dizziness, vertigo, any sort of issues with their balance. And something known as a vestibular apparatus is used to test this. You're not going to see that done very often. That would be done by a specialist, so I don't expect you to know how to do that. Just know that the vestibular part of it has to do with testing like balance, equilibrium, those types of things. And then the cochlear portion of it has to do with hearing, both conductive hearing, which is like hearing through like waves, and then the bone conduction hearing, which is hearing through like, we also like perceive sounds through the bones in our ears and our head. So those things can be tested through something known as a Weber and a Rhine test, and that is used with the tuning fork. You can also look up on YouTube how these are conducted. I'll briefly explain how they are done. So with the tuning fork for the Weber test, you'd hit the tuning fork on your hand and it should start to vibrate. You would place it on the top of the patient's head, right in the middle, and you would want it to like touch their head. And you would ask them if they can hear the sound in both or one ears. They should be able to hear it in both ears, and it should be equal on both sides. That would be a normal finding. And then with the Rhine test, you would do the same thing. You'd hit the tuning fork on your hand. It should start to vibrate, and you would put it on that bone behind the ear. And you would tell them to tell you when they can no longer hear that vibrating sound. And then once they told you that, you would move the fork right in front of their ear, like the ear canal, and tell them that to tell you when they can no longer hear that vibrating again. They should be able to better hear when that tuning fork is moved to the front of their ear than when it was sitting on that bone behind their ear. And those can just help determine different types of hearing loss, if their bone conduction hearing is working, those types of things. You can also do something known as the whisper test. And this is just a very basic, kind of unofficial test. Obviously, if we really thought somebody had hearing issues, we'd do something more specific and extensive. But all you would do is whisper something a few inches from their ear and have them repeat it back to you. And if they couldn't repeat it, then obviously they may need more extensive hearing tests. You could also rustle your fingers and move it further and further away from your ear and have them tell you when they couldn't hear it any longer. They should be able to hear that for quite a while. Obviously, if they can't, then they need to be referred to audiologist, ENT, something like that. Then the next nerve that we would assess is cranial nerves 9 and 10. These are assessed together, and these are known as the glossopharyngeal. So think like throat, because of pharyngeal, and then the vagus nerves. And these test like our gag reflex and stuff in the back of our throat. So you would want to test the gag reflex simply with like a tongue depressor or Q-tip or something like that. And then you'd also want to have the patient say, ah, and their uvula in the back of their throat should vibrate. And that lets us know that both of those nerves are intact. Obviously, it's very important to test a gag reflex because if our patient has an absent one, then they may be at risk for aspiration, unable to swallow things appropriately, those types of issues. And then the next nerve, cranial nerve 11, is known as the accessory nerve. This does test our sternocleidomastoid and trapezius muscles. So those are the ones like along the top of the shoulder, along the neck. So the way that you would assess those is you would place your hands on top of the patient's shoulders and kind of gently press down and have them shrug against that resistance. Then you would place one hand on one side of their face and have them press down, and then place your hand on the other side of their face and have them press down, and they should pretty easily be able to overcome that resistance. You'd want to note asymmetry, so can they do it on one side, not the other? Is one side weaker than the other? And then also note any sort of atrophy that is going on with the muscles. And then the last cranial nerve is the hypoglossal nerve. So that's cranial nerve 12. You can also assess that with cranial nerves 9 and 10 if you want. This nerve has to do with the tongue. So when you see glossal, think tongue. So the way you would assess this is you'd have the patient stick their tongue out, have them move it side to side, up and down, push the tongue against resistance of the tongue blade. Once again, you'd want to know any sort of asymmetry or inability to do any of these functions. So those are your 12 cranial nerves, and that's how you assess them, and that's everything that they control. So next we'll talk about testing motor function throughout the rest of the body. So we would want to test somebody's strength, and we'd want to do that in our lower and our upper extremities. So the easiest way we do that is have them push against resistance. So I may place my hands under theirs and have them push down, and then have them push up against my hands. They should be able to easily overcome that resistance. With their lower extremities, I'll have them push their feet against my hands and then curl their toes back against my hands, and that can give me an indicator of strength. Once again, you'd want to know any sort of asymmetry. You'd want to test both sides. Something else that you could do is assessing for pronator drift. So how we do this is we have the patient hold their arms out and close their eyes, and then have them place their palms up for 30 seconds. If one arm starts to drift down and that palm starts to turn in, then they have a positive pronator drift, and that indicates a problem with their motor cortex on the opposite side. So if the right arm does it, then there's an issue on the left side of their brain, and vice versa. Another part of assessing motor function is noting the muscle tone of the patient. So that can go anywhere from hypotonia to hypertonia. So hypotonia would be like very flaccid, like floppy muscles. And then hypertonia would be spastic, very like tight, clenched muscles. So you may see like somebody's arm drawn in or their hand drawn in. That would be considered hypertonia. You see that a lot in like CP patients and stuff like that. You can see hypotonia in people who are paralyzed. Myoclonus is known as a spasm of the muscles. So you'll see that like if somebody has like a tic or a tremor, that's considered a myoclonus. Athetosis is slow, writhing, involuntary movement of the extremities. You can see that in diseases like Parkinson's. Chorea is something that is pretty unique to something known as Huntington's disease, and this is just involuntary, purposeless, rapid motions that the patient does. They have no control over them. And then dystonia is the complete impairment of any muscle tone, and you'll see that too in patients typically with paralysis. So we also will be assessing, the cerebellum, which is another portion of our brain. It's located at the bottom in the back, and it controls balance and coordination and our posture. So an easy way to test it would just be having that patient watch them walk across the room, note their gait. Are they shuffling? Are they stumbling? Are they at risk for falls? Are they slumped over? Or do they have like a nice, smooth, steady gait? If the patient's unable to walk or we consider them a fall risk, we can have them do the finger to nose or heel to shin test. So the finger to nose test would be you hold your finger out in front of them about arm's length, and you would tell them to touch their nose and then touch your finger, their nose, touch your finger, and go back and forth pretty quickly. They should be able to accurately hit both points. If they're constantly missing your finger or their nose, that can indicate an issue with the cerebellum. If for some reason they can't do it with their hands, then we can do the heel to shin test. So an example of that would be taking their right heel and sliding it down their shin from their knee to their ankle, and then doing it on the opposite side as well, left heel down their right shin from knee to ankle, and they should easily be able to do this. If not, once again, that indicates an issue with their cerebellum. Always note symmetry. Can they do it on one side, not the other? That's always important with neuro. And then we also have the sensory component of the rest of our body. So we'd want to test the sensory function on all four extremities and on the anterior, which is the front part of our body, and the posterior part of our body. We always want to have the patient's eyes closed when assessing this. Once again, we can do this with that sharp dull test. We do it on the arms, the legs, the front, and the back. Once again, you do the whole, is this sharp or is this dull? Or you could ask them how this feels. We can see them neglect one side and not notice any of the tests that you're doing with those right hemispheric strokes. So that would be a way to test if they're neglecting a side. If we notice they're not feeling pain in a certain area, that can indicate sensory dysfunction. If we notice, we can also assess using like different temperatures to see if they're not noticing temperature changes, because that indicates sensory issues. Typically, we only do the temperature thing if somebody is not responding to like deep pain stimuli. So that would be something that we're almost testing to see if there's any sort of brain function at all. And obviously that whole sharp dull test would be done on a patient who can respond to you and appropriately answer questions. Another way we can test the sensory functions of the body would be through some other different tests. So one would be the vibration sense. That can be tested using a tuning fork. So once again, you'd hit that tuning fork on your hand and put it on different bony prominences, like on the wrist bone, on their legs, on their feet, their ankle bone, and you would just have them indicate to you when the vibrating stops. We can also test balance and all of that, again, with the Romberg test. So how we do that is by having them stand with their feet together and their eyes closed. A lot of times they'll have people hold their arms out. If they can maintain their balance, or if they start to like get wobbly and stuff when their eyes are closed, then that indicates that we may have an issue with that cerebellum or some sort of balance issue, vestibulocochlear dysfunction issues. We can also test their proprioception, which is the awareness of where your body is in space. And so how we do that is by closing the patient's eyes, and by taking either like their index finger or their big toe, and we'll take it and we'll point the index finger up, point it down, and have them tell you, is your finger up or is it down? And they should be able to tell you just based on feeling that, where that finger is in space. We can also test different cortical sensory functions, so the cortex of the brain, through things known as graphesthesia and stereognosis. So graphesthesia is the ability to recognize something traced on your skin. So you'd have the patient close their eyes and you just draw a simple, easily recognizable object on their skin, like a heart or a star, and they should be able to tell you what it is. With stereognosis, you would have them close their eyes and you should be able to place a recognizable object in their hand, like a pencil or a watch or a spoon, something that they would know what it is just by feeling it. And then the reflexes of a patient also need to be tested as well. We do have different reflexes throughout our body: biceps, triceps, brachioradialis, patellar, and Achilles. We rate them. Some people rate them on a scale of 0 to 5. Some people rate them on a scale of 0 to 4. It depends on your institution. But 0 is considered absent, and then the highest number on the scale is considered hyperreflexive. So it may be a 5 or it may be a 4, depending on your institution. But hyperreflexive would mean like sustained clonus or movement of that particular muscle. And 2 is always considered normal. You don't have to specifically know how to test all of these. You can look at it in your book, or you can look it up on YouTube if you wanted to see more how to test them. It's kind of hard to explain on an online lecture, but these are typically not tested most of the time unless like a specialist or somebody comes in. Okay, so now that we've talked about assessing the neurologic system, we'll talk about the different diagnostic tests that are done if we are suspecting neurological problems. So the first one we'll talk about is the cerebrospinal fluid analysis, CSF analysis. And the way that we typically gather or collect CSF is through a lumbar puncture procedure. The reason we may need to collect CSF is it can tell us a lot about different central nervous system diseases. So it can be important. So it can help us gather that data. Normal CSF fluid is clear, it's colorless, it's odorless, there should be no blood in it, it shouldn't be cloudy. It should honestly just look a whole lot like water. You do want to take note that if somebody that a lumbar puncture is contraindicated in a patient who has an increased ICP, or we suspect that they have an increased ICP. You would never do a lumbar puncture on these patients because it can cause their brain to herniate. We would also not want to do it if they are at risk for getting an infection at that possible puncture site of the lumbar puncture. So how this is carried out is a needle is inserted into that lumbar subarachnoid space, typically between L3 and 4 to L4 and 5, so that lower back region, and we withdraw the CSF for testing. There must be strict aseptic technique because we do not want to introduce bacteria into that system. It can cause lots of problems. If we saw blood or something in the CSF, that would mean that the spinal tap, that's another name for this, wasn't good or it was compromised, so we need to get another one because CSF should not have blood in it. So how we prepare these patients typically is they'll be placed in that lateral recumbent position, so that's laying on their side, typically their knees drawn up, and we want them to kind of push their spine out because that makes that L3, 4, 5 area easier to access and visualize for the physician. So you, as the nurse, would want to help them get into that position. You could also have them like kind of sit on the edge of the bed and lean over a table or a pillow and push their spine out. You see that done a lot with like epidurals and stuff. But most of the time for lumbar puncture, they're in that lateral recumbent position. Typically why we would do a lumbar puncture would obviously be to obtain CSF, like I said. Sometimes they would do a lumbar puncture to insert a catheter to measure pressures within that CNS system. And also sometimes a lumbar puncture is done to insert a catheter so that we can administer drugs intrathecally. And the reason we'd want to do that is if somebody had a CNS infection and we needed to get those drugs to that area, we could do that intrathecally, so get them to the brain or the spinal cord. So those are the 3 reasons we do a lumbar puncture. Most of the time you see it done, though, to obtain that CSF to determine if there's like an infection or something going on in the CNS system. So I told you the patient needs to be in that lateral recumbent position, strict asepsis. They would have to sign a consent. And then during the procedure, you just want to be with the patient, support them. Obviously, we're always probably going to monitor vital signs. And then post-procedure, you would tell the patient that they needed to lay flat for a few hours until the physician says they can start to get up. A lot of the times, patients can have a headache from these, and the headache is supposed to be horrific, like horrible. If they do experience that headache, obviously we're going to keep them laying flat, put them on bed rest, give them analgesics to help with the pain. We want to hydrate them, so give them fluids, and they possibly may need a blood patch. And the reason patients experience this headache is because of that hole that was made in that space. Some CSF is leaking out, and so that causes a headache. And usually it should seal off on its own, but sometimes it doesn't. So that's when a blood patch is used to kind of seal off that area. And that's also why we try to hydrate the person with IV fluids, because that can help replace that lost CSF and help actually get rid of the headache. You would also want to assess the site that the lumbar puncture occurred for a leak, infection. You'd want to monitor the patient's vitals, their neurological status after the procedure as well. So that's a lumbar puncture. Next, we'll move on to the CT scan. So, a CT scan you've talked about in all other semesters, so you should have a pretty good idea of what goes on with this. In this case, we would be doing a CT of the head. It is the primary diagnostic test for lots of neurological things. It's fast, it's easy to do. The important thing is that the patient just does need to lay still while it is going on. They don't have to lay still for that long. It's a fast diagnostic test. If we're having to use dye for the CT scan, then informed consent would need to be signed by the patient, and they would need to be NPO 4 hours prior to the test. Remember, if we're using dye, then we also need to assess the patient's allergies. So are they allergic to shellfish, iodine? We'd want to note their kidney status because dye is hard on the kidneys. So we'd really want to give them fluids afterwards, flush that dye out of there, hold the metformin, those things. So think about anytime you give contrast or dye, what you have to do with those patients. CTs are good for seeing things like blood in the brain, edema, those types of things, old infarcts, tumors, those issues with the brain. Sometimes these do require IV sedation. If the person's really like claustrophobic, I mean, these aren't as bad, or if they're not really alert or not following directions, they're agitated, they may need it as well. Okay, and so next is the cerebral angiography. This is done to look for vascular abnormalities. So that's like issues with the blood vessels in the brain. So typically these are done to look for brain aneurysms or cerebral aneurysms or something known as arteriovenous malformations, AV malformations, which is just like a weird kind of way that somebody's blood vessels are connected and made in their brain. It is the gold standard for visualization of the arterial system within the brain. It's essentially kind of like an X-ray of that cerebral circulation. What they do is they'll go through the femoral artery just like they do with the heart cath. So taking care of this patient is going to be very similar to that. They'll use the dye again, so we would need the consent. You'd have to think about all the things again with the dye, BUN and creatinine, holding metformin, checking or giving fluids afterwards, checking allergies, those types of things. Like I said, and then aftercare is going to be very similar to what it would be for our cardiac catheterization. So they're going to have to lay flat. You're going to have to assess that injection site. You want to make sure that they're not bleeding from it. Also, because they're having neurological issues and we were looking at the brain, you'd want to check level of consciousness, motor or speech problems, weakness on one side. Typically, they're on bed rest for about 4 to 6 hours after they've had the procedure, and that's just because they went in through the femoral artery. Before the procedure, I did forget to mention they would need to be NPO for 8 to 12 hours. So that is the cerebral angiography. The next one we'll talk about is an MRI. You should have discussed those already in multiple semesters. This can be used to diagnose certain things such as multiple sclerosis. It can give us a more definitive diagnosis of a stroke. A lot of times you can't really see those ischemic strokes on a CT scan. The CT scan is really just done to rule out any sort of bleeding in the brain. But an MRI can tell us more specifically if a stroke occurred and what damage occurred. It can tell us if there's herniation or some sort of trauma. It provides more detailed images of the brain, the spinal column, and the spinal cord. So it can see things that a CT scan can't see. So the way we prepare somebody for an MRI, just a little review, you are going to tell them that they'll be communicated with through a microphone. They can speak back as well. You'd want to remove all metal objects before entering the room. That includes snaps, buttons, medications with metal backing. So like, I guess certain like patches or something like that. It can also deactivate credit cards. You'd want to assess any sort of, if they do have metal hardware like pacemakers, cochlear implants, metal rods, if they are MRI safe. Typically, they'll have a card that they carry with them that says that they are. Sometimes too, you may have to wait a specific period of time so that the device is stabilized before they go into the MRI machine. Some patients may need sedation. So you'll need to take that into consideration. If they have old tattoos or tattoos they got in the military or in prison, those can contain metal. So that would be something that you would want to assess for on the patient. You would also want to tell them that it is going to be very enclosed and that they're going to hear a loud thumping sound. So you'd want to prepare the patient for that. Then there's also something known as an MRA, which is like an MRI angiography. It's very similar to that cerebral angiography, except an MRI machine is used, but the dye and all that stuff is used. So you'd want to take all those things into consideration as far as dye goes. And then the next one are just x-rays. There's not a whole lot to an x-ray. We know that it's just something that is used to look at bones. It can't really visualize anything else. Typically, we would just use it to look at for a skull fracture or a spinal fracture. There's no prep for it. There's no monitoring really after it. So it's a very simple, easy thing to do. Whoops, I need to go back one. So there are also other studies that can be done as well. An EEG, this records the electrical activity in the brain. So think of it as very similar to like the EKG of the heart. An EEG does a brain. It can tell the origin of seizure activity or other cerebral diseases. Client instruction would include no caffeine before the procedure. You'd want to hold any sort of sedatives. They don't have to be NPO, so you don't have to worry about that. You'd want to teach them to wash their hair before the procedure and then not put any sort of product in it, like no oil, sprays, gels, anything like that. And after the procedure, you would want to teach them they'd probably need to wash their hair again to remove the glue from the electrodes. During the procedure, you'd want to teach the patient they may be asked to take deep breaths. They may be exposed to flashes of a strobe light during the test to try to induce a seizure so that they can see the seizure activity. Certain EEGs, sometimes sleep is withheld, sometimes it isn't. It depends. So it may be withheld prior to the test and then possibly induced during the test. So it really depends on what's going on with the patient, what the provider wants. Sometimes you may need to hold their anti-seizure meds and tranquilizers prior to the study, and that's because they want to visualize the patient having a seizure. We can do EEGs for a couple different reasons, like I said, to diagnose seizure disorders. We can also do them if we're checking for brain activity for somebody who's in a coma, and it can indicate to us if there's brain death or not. It can also help us diagnose certain sleep disorders. Sometimes we'll get a baseline EEG first of the patient before doing any sort of diagnostic EEG. And then a PET scan is another test that can be done, and this measures the metabolic activity of the brain. And it tells us about cell death or damage that is going on within the brain. A lot of the times, PET scans are done in people who've had a stroke, who possibly have Parkinson's, Alzheimer's, brain tumors. This is done in Nuke Med. So radioactive material is given to the patient through an IV. And then it helps visualize certain areas of the brain. They show up as bright spots. I'll show you a picture of it in a minute. The patient typically does have 2 IV lines. It doesn't require any sort of sedation, and we always tell them that they need to empty their bladder before getting their PET scan. And then don't worry about myelogram. You don't see those done too often, so we won't go into real detail about that. So here, I'm just showing you examples of some of these different tests. Image A is what a CT scan looks like, and then image B is what an MRI looks like. So you can see an MRI gives a lot more detailed picture than a CT scan does. So that's why it can be more beneficial to us with diagnosing certain things. And then here, this shows what a PET scan looks like on a normal brain versus somebody with advanced Alzheimer's disease. The yellow areas indicate metabolically active cells. So we can see we've got lots of activity going on here in a normal brain versus in that Alzheimer's brain. We don't see as much activity. And then this here shows a cerebral angiogram. Remember, that's that gold standard for visualizing the arterial system of the brain. That's where the dye is inserted. It's similar to like the heart cath, only we're looking at the brain. And you can see here, this is known as an arteriovenous malformation or an AV malformation. This is like how it's kind of like you've got a bunch of messed up blood vessels in your head, and those can lead to issues down the road. And that is it for this lecture.